Thank you. Greetings and welcome to today's presentation titled 988 Year 1, Milestones and Next Steps. Before we begin, we would like to remind you that this is a safe and friendly space for positivity and productivity. There are a few housekeeping items I'd like to quickly go over. This presentation is being recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. This information will also be available on the National Council for Mental Wellbeing's website and NASHMED's website and YouTube channel. Please use the chat pod to share your name and state, ask questions, and/or share information with the group that pertains to this presentation. Closed captioning can be viewed by clicking the CC at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who is spotlit on your screen. When the presentation ends and you leave the meeting, a brief survey will show up in your browser. Please take a few moments to share your comments and your thoughts about today's presentation. We would like to give special thanks to SAMHSA for sponsoring this presentation, and again, thank you for joining us. I will now turn this over to our first presenter, Monica Johnson. Thank you, Monica.
Good afternoon. Thank you, Kelly. Thank you all for joining us on this anniversary day. It's the day after of the official 988 one-year anniversary. I'm so excited to be here with you all today and to spend a little bit of time talking about where we are and what this year has looked like and what's ahead, what's on the horizon. For those that aren't familiar with me, I'll take a few minutes to tell you a little bit about myself. I'm the director for the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA. I joined SAMHSA in January of this year. And prior to joining SAMHSA, I worked in state government in the great state of Georgia. I worked for the Department for Behavioral Health and Developmental Disabilities for 12 years in a variety of roles. Most notably, and the longest, was the Division Director for Behavioral Health, and the interim commissioner was my last role before I left the department. And so it is my honor and privilege to be here. I think it's important for you all to also note that prior to coming into state government, I spent many years in community settings. My very first job was a tech, a paraprofessional in a child and adolescent psychiatric treatment facility. And so if you had asked 22-year-old Monica at that time, did she think that this country would be having the conversation that we're having now around having a 3-digit number that is a national number that anyone can call that is experiencing a mental health emergency, substance use emergency, thoughts of suicide, whatever the crisis may be? I would have said, no way. And the fact that this is where we are now is just amazing. So we'll spend a little bit of time today. You'll get to hear from me and my esteemed panelists to give perspective around where we believe we are. Here's an interesting tidbit for me before I move into the full presentation. So I could not have planned this any better if I had tried, and I promise you I did not try. But for this 12-month reflection, the first 6 months, I was on the state side working to help lead the implementation rollout for the 988 system in Georgia. And I had no clue I would spend the next 6 months of that year, that 12-month period, from this lens. So I have a very unique perspective, 6 months from the implementation side. So have a very, very clear understanding of what it feels like for states and providers and local communities to do this work. I have not lost that perspective. It literally was just yesterday is what it feels like. But then I've had this now bird's eye view from the federal level. And so it's quite fascinating to have both perspectives within the same year. So just an interesting tidbit. So with that, we'll move on into the slides. Next slide, please. So today, what I'm going to focus on are primary 4 kind of buckets. We'll do a little bit of reflections, talk about what have we learned, what did we do in year 1. There'll be plenty of things that won't be in these slides that won't be reflected, and that's only because I don't have 8 hours to do this seminar with you today or webinar with you today. We'll talk about emerging issues. There are some things that are, I know, at the top of many people's minds in this audience. And so we'll talk about some of those things and hit on some of those at a high level. And then we'll talk about what's ahead. And so what are we looking to do as we get beyond and move now officially today is considered moving into year 2, and how appropriate that we get to do that with this particular audience today. And then we'll spend a little bit of time talking about the big picture around the crisis care continuum. Next slide, please. So I am not going to assume that everybody that is listening to this webinar has been here from the beginning. We have turnover in this field. And so I do want to take a minute to just level set, right? And just remind us why we're doing what we're doing and what brought us to this point in time. So there's some data and some statistics here that I like to share when I'm doing this type of level setting. I'm not going to read each one of them to you, but you can see here that there are some pretty remarkable drivers that got us to where we were. Since the pandemic, we know, without even have had this data, we knew that as a country, we were growing a little bit more ill and sicker and needed more support. All of us did. As we think about our mental well-being, all of us experienced something at some point in time that made us have to take a different look about how we talk about mental health. And I like to talk about it in terms of a space of wellness. What has happened in the last 3 years coming out of a pandemic is now we can change this conversation around, it is not just about a group of people that we're talking about over here, that you have to have this very specific diagnosis for us to be talking about you as the target group here, right? We're talking about a conversation that is inclusive of all of us, present company included, right? And so now what is starting to happen, and I am grateful to be in the space to see this and witness this, that we're changing the conversation about how we talk about emotional wellness, mental health wellness, behavioral health wellness, all of that in a way that is more about all of us and not just some of us. And I think that's important. So you see the stats here, you see the data, you see what the drivers were. The one obviously that jumps off the screen is the second one. There was approximately 1 death by suicide every 11 minutes in 2021. So this country was clearly experiencing, and still is, a crisis. And so what needs to happen in order to be responsive? So while this is not a system that was just built, post-pandemic was not just built when 988 was rolled out a year ago, because we're talking about a whole continuum of care. And for those of you that have never heard me talk about this, let me do a little spoiler alert. You're going to hear me say more than one time that while we're talking about a conversation from a lens of what does the crisis continuum look like, I'm going to always talk about the entire behavioral health continuum, because you cannot build a system on crisis alone. You always have to be still talking about and paying attention into those upstream prevention services. We do not want to send a message where we are telling people we want to wait till you are experiencing a crisis before you reach out for help. Help is available prior to experiencing an actual crisis, right? And so what do we do to prevent? And then what do we do when the crisis is over? Crisis is a moment in time. And so we must be building out those support services, such as your CCBHCs, et cetera, across the continuum. So that's important to me personally, and it will continue to be as we talk about this continuum of care and this blueprint that we're talking about. How do you put all these pieces and effectively thread them together, that you don't have to be in the system or be someone who is conversant in the terminology that we're going to talk about, because we're all working the same field, right? But an everyday person that is just wondering, how do I get help? That should be an easy thing to do. 988 helps set the stage for that. And it gives people a starting place to reach out for help and support. So that's how we got here. Next slide, please. So as we think about what did we learn from July 22 to the present, this says that that the 988 Suicide and Crisis Lifeline has received more than 4 million contacts. It's actually a little bit closer to 5 million contacts. That's calls, texts, and chats all combined. That's an average of about 360,000 contacts monthly. And like I said, it's actually a little bit higher than that. Which is remarkable, especially considering that we have not had this, mass marketing campaign. This has just been through the work that states are doing, that is happening at a local level, the support that we are trying to lead in here with you all, but this has been the biggest group project to ever exist. So this takes all of us, right, having our own local ways in which we are getting this information out, and we were still able to see an increase. Is it the number that I want to see? No, there are more people out there that that would benefit from knowing this number exists. I could go into my local grocery store right now. I promise you, if I get on the little microphone and say, hey, everybody, this is not about any sales going on in the store, but I have a question. I want to know who knows about 988. I imagine that many people in that store would not have heard about 988. So while I'm extremely excited about where we are, and I want to sit in that moment, and I want to be, proud of that, especially on a day like today where we are in a celebratory mode. But I also want to keep my mind open to, I know there are far too many people that do not know what 988 is. And so we will be continuing to make sure we're pushing this message out, and I'll say more about that later. When we do a data comparison and look at May 22 versus May 23, we can see that the Lifeline answered about 160,000 more contacts and significantly improved how quickly those contacts were answered. Calls answered increased by 45%, chat increased by 52%, and you could see the astronomical increase in texting. Now, true part of that is because texting wasn't widely known to be available via the Lifeline. And so now that people know that, they've been using it, and that's why that looks really, really huge. But nonetheless, it's a significant increase, and it lets us know that the message is getting out, but we still just have more work to do to make sure that we're getting it out to the masses. And even when I say that, because I don't want to take away the celebratory way I feel today, because I feel happy today, and I want to stay in my happy space. So staying in my happy space, I also have to level set and remind myself, we are talking about year one, right? It is still just year one. So we're moving into year two now, but I mean, it's been a year. So the realities of where we should be and where we can be doesn't mean I don't have to really want to obtain it, but I also have to level set sometimes, just do my own gut check about the realities of where we are. So during that same time frame, we saw a significant improvement in how quickly contacts were answered. So from the data, we can see it went from 2 minutes and 20 seconds down to 35 seconds. What's important about this slide, in addition to the data, here's the takeaway and here's the story. We demonstrated in year one that as a part of this big group project, we were able to do the number one thing that I know was on everybody's mind. If somebody dials 988, will call centers around this country have the capacity to answer those calls? So we did that. The answer was yes. So we did that, and we should celebrate that. And we should not move so fast past that we don't remember. I remember the level of anxiety that I had when I was on the other side of this the first 6 months ago. I know I have some old colleagues here from Georgia that can attest to this. The anxiety that we felt, and I know that was shared amongst our brethren across the country, where we were very worried about, we need to make sure we have the capacity to answer the calls. Well, guess what? We did. And we did that collectively. And so I'm proud of that. And while we still have work to do, it is something to be proud of. And then the other takeaway from this slide, again, is the response time. Because it would have not been great if we had the capacity, we had people, but then we were still making people whole for an unnecessary amount of time because we truly didn't have the capacity that we needed to be able to make sure that not only would the call get answered, but that it would get answered quickly. By the time somebody calls 988, they're experiencing a crisis. And so having people have to wait more than a minute, 2 minutes, more than a few seconds is far too long. So the fact that we at least were able to move from 2 minutes down to 35 seconds, I think deserves a round of applause. So those are the stats in terms of what we see nationally as we look at our data in this year. People are getting connected, people are reaching out, and the call centers are being able to be more responsive and not have people waiting in a moment that they are at their most vulnerable point in time. Next slide. So as we continue to look back at year one, there's been some very significant investments. There's been nearly $1 billion from the Biden-Harris administration that has helped strengthen and expand the 988 Lifeline capacity. It's an unprecedented amount of funding to help build this, to help put the infrastructure in place, hence why we're able to be, to have some of those data points that we're talking about. And it shows up in different ways. And so all of this is not money necessarily to the 988 office. This is all throughout the system. Some of it shows up in block grant funding. So you see it in different ways, but the investment is there. And that's very, very exciting. It continues to feel very bipartisan, which is important, that this has been an issue that everybody wants to talk about, no matter what side of the aisle you're on, just because the issue resonates. This conversation that we're having about accessing mental health services when you're in a crisis, pre, post, and beyond, it resonates with everyone. And so that seems to be something that continues to happen. Then again, I feel like I hit the second one. In terms of the second bullet though, so it talks a little about the increase in the call, text, chat volume and the answer rates. But what's important here is the partnership. And so this feels like a new level of enhanced coordination between states and the federal government. Obviously, the contact centers and the call centers have had a long withstanding relationship with Vibrant Emotional Health, who you all know we contract with to oversee this work, and they've had a long relationship already with the contact centers. What is new and a new dynamic is now the states are at a level that at the table in a way that they may not have been before. And so it's a bigger party. We're bringing more seats to the table because we're now talking about not just the work that happens in the contact centers, which is vital in the backbone of the 988 operational work, right? But now we're talking about that, and we are talking about behavioral health crisis, healthcare crisis continuum. And so that then changes the conversation a little bit. And so states now are having to ask the question, so what does our system look like? What do we do to prevent people from going in crisis? What is needed to fund a full crisis continuum? So it broadens the conversation. At no other point in time that I can recall, and I'm waiting for somebody to check me on this because I say it often, can I remember a time, I've been doing this 26 years, almost 27 at this point, for a very long time. And I don't remember any other moment in history where all states are talking about their behavioral health crisis system at the exact same time. And so I think it's worthy to underscore, bold and underline and repeatedly say how transformative that is. So this level of coordination that has to happen between the federal level, the state level is I think newer, and it is the right work that needs to be happening. And this is how we will be able to together drive towards this blueprint of what should this system look like. State, territory, and tribal nations are taking these steps. Not only are they having these conversations, but what we know is about 50% of those states are passing different types of appropriations, different types of laws to fund different parts of 988 related services. So rather it's 988 support for call centers capacity, rather it's a study commission being formed, rather it's actual appropriations, whether it is the fee, cell phone fee, whatever it is, there is a lot of activity happening that backs up what I'm saying around all these states are having these conversations at the same time, and they're not just words. And so we can see that. Rather it's funding for mobile crisis teams, rather it's co-responder work, rather it's whatever it is, there's a lot of things happening in this country right now related to this work. We've enhanced technology across the 988 Lifeline system. We've bolstered our cybersecurity. We've launched a new learning management system for crisis counselors. We've expanded the 988 Lifeline Partner Network to include tribal communities as a part of our SAMHSA grant making. Next slide, please. So as we think about moving ahead, and I could have spent 20 more slides. Y'all should have saw the sausage making process for this. There's so many things I want to say to you all and so much I want to talk about, but there's lots of things that we could have put into the what did we learn in year one that didn't make the slide, but it does not mean that that's all y'all want. No, it's a lot more that we could talk about, but for the sake of time here, that's what I'll get to. But we learned a lot in that year. So I haven't really separated the years. And so the slide is going to direct me to go to year 2 and talk about what's coming up. But yesterday was the technical 1-year anniversary. And I'll tell you that it feels just like Saturday felt. So these days are just running together for me. And so I am still driving towards the same things that I was driving towards when I came in the door in January. But to point out what some of those things are, this is not an all-inclusive list. We obviously have some priority populations based on data that tells us that there are some groups that are more at risk and very vulnerable. And so we have prioritized some groups. So we started a pilot program several months back to offer specialized call, text, and chat option supports for individuals or young adults that were primarily 25 and under that were LGBTQI+. That pilot is now out of a pilot phase, and it is now what we do. And so we will continue to offer specialized support so that these individuals have an opportunity to be connected with individuals that we talk about lived experience and shared experiences. And so that feels important for this group to be able to have that option. And so if I'm an LGBTQI plus youth or young adult, and I want to be connected to a crisis counselor that I feel like will share experiences, will be culturally competent, and be able to meet the needs that I may present with, then that is something that will continue to support. Spanish text and chat services were officially announced and launched last week. So here it says by the end of this fiscal year, but that big announcement came from our HHS Secretary, Becerra, who announced this at an event last week, and we're so excited about this. It kind of completes the triad here. And so adding Spanish text and chat services is a huge deal in allowing just more opportunities in which individuals that want to be connected with someone who speaks Spanish will now have the opportunity to do that, not just via call. Coming out soon will be video phone services for individuals who are deaf or hard of hearing, for whom video phone is the preferred method of communication. I'm really excited about this as well. A part of my previous work included overseeing if Kelly Sterling is on here, I'm gonna shout out Kelly Sterling, who's doing great work in Georgia related to advancing that system as it relates to individuals that are deaf and hard of hearing and in need of behavioral health services and access to culturally appropriate services. So this is a really big deal for me to make sure that everywhere we can, that we are looking at ways at improving access in every which way we can. The next one is around partnering with tribal nations. I'll tell you that this one is like probably, I don't want to put a number to it, but it's in my top priorities, and it has been since I stepped into the door. I've been getting around this country a little bit more. They let me outside finally, and so I'm out there. So I'm going everywhere, and getting engaged with tribal communities has been really important to me. Understanding what are the different needs, how can we make sure that we are building systems and services that include, that are accessible for all of us, and what does that look like? And this is a really important partnership for us. And so working to do that, including training counselors who are culturally and linguistically aware, Crisis Center Academy for tribal grantees, and so much more here that didn't get captured in the sub-bullet, but that we're working on and we'll be doing more of as we move forward. Next slide, please. We'll continue to enhance outreach and education. I was recently asked, like, what's kind of one of your biggest like pain points or things that kind of lightweight stress you out? And I was like, I get to pick this one, and it's around outreach and education, because we have to be able to get this message out. And so expanding our reach, encouraging help-seeking behaviors, and continuing to decrease stigma is just kind of the core of all of this, right? And so we got to be able to do more of that. We're looking at ways in which how we can continue to help support states do this work through funding opportunities. Some recent NOFOs that were put out on the street definitely did talk about building out local comm strategies, communication strategies, and planning. We're doing that on our end, trying to be very strategic about how do we make sure we're targeting the right audience? How do we be smarter about engagement, et cetera? And so this is just really important. It's fundamental, kind of like one-on-one, because we assume, because this is our world, right? This is the space we live in. We collective, all of us, because remember, this is one big group project. So all of us live and breathe this work, and we assume everybody else just will know this and it'll make sense. Like, of course, it's easy to tell what's the difference between 988 and 911. Well, no, there are people with lots of questions about what's the difference, right? Even when I've had the opportunity to speak with and be present with leadership members from the law enforcement community, there's lots of education and communication that we have to do collaboratively so that we can do those kind of joint communication efforts. So there's so much to do there, and I'm excited. And the other thing I'll just say here is, because I get this question, how do you convince people that may not feel like calling 988 would yield a positive result, that the police will be sent to them when they don't want them to be sent to them? This is the kind of outreach and education that I'm talking about, right? And so fundamentally, just walking through what to expect when you call, what happens when you call. So helping to decrease the mystery of what happens behind calling, right? Or reaching out, texting, chat, however, what happens. And so how are we talking about that in our communities? How are we getting that information out? It's really important. And we really rely on what you're doing locally as well to help drive some of that work. We'll be publishing a lot of things, but one of them is a toolkit providing guidance for law enforcement's response to crisis situations. That activity is really a part of a bigger bullet that should be on here. We are standing up a 988 crisis technical training and technical assistance center. And so we're excited about that. It is in its very early infancy. And so this type of activity, like that law enforcement guidance, will be something that comes out of like that center, for example. We'll be conducting a learning collaborative for states. Again, that would be something that would come out of the Training and Technical Assistance Center. But that collaborative for states on the mental health crisis continuum with the focus on best practices for mobile crisis response, et cetera. We're talking about, how do we bring all of us together to convene, like there's mechanisms in which we can talk to states and we can talk to our contact centers, but how do we all come together? And so we're cooking up some things there. So that was a teaser to get us all together to convene and do some learning together in person across our different parts of the group project subcommittees. All right, next slide. So I am nobody's fool, and I can sit here all day and tell you all the things that are going great. But there are some things that we have opportunity to improve, right? And so we know what those are. And this is not an all-inclusive list either. And so where we are looking at trying to be better and trying to improve and make sure we're keeping our eye on. So the data variance conversation. This is something that the moment I came in the door, obviously I had some awareness of, because I had just literally come from the state. So I understood this issue. I understood the challenges that it brought. And so therefore, this became something, obviously really important for me to try to understand, as I had to look at it from a different lens. And so we have been taking a lot of steps to, one, be better communicators around why these data variances exist. There have been webinars, there have been open office hours is what we call them, where we are talking very directly about what we see and why we see these data variances. And what we have seen is some of these data variances have gotten better. They're not perfect, and not every state can say, okay, they're now like everything is great. We're never going to see a 1-for-1. And so we're not on the same platform. So it's not going to ever be, that's not our goal, is that it matches 1-to-1, but there should be a reasonable plus or minus, over under that is in the realm of being okay, right? And so that's what we're driving towards. And so that remains a top priority for us. And if you are experiencing, I hear when people say that there's a data variance issue, I literally hear from that state. And so I will say that those contacts have gone down, but we continue to monitor this issue. It's something we're working on literally every day. It's a part of our day-to-day work. Federal state center relationships and decision making. So remember this group project, I keep underscoring that this is, well, it's like I said earlier, like we grew. And so again, the contact centers, the call centers, the crisis centers have been answering calls for a long time. You all answer calls that are not just the 988 routed calls, just like before the 988 transition, when it was the 10-digit suicide prevention number, right? You have other books of business that you're managing calls for. And so those different relationships were the way they were because how the system was set up. But now with 988, all of us got to be talking, or we're going to fail the group project. So we got to figure out not only like who does what, but make sure we're giving you all clarity on who's responsible for what parts of this, right? And what does that look like? And I cannot wait to have these dialogues with you all, rather it's via me coming around and talking to some of the states like I've been doing and some of the call centers, or when we have this thing I just kind of previewed is coming at some point, our little convening that we're talking about. So it makes it a more complicated, but it's good because it brings all the right players to the table. So that's just a complexity that has been brought about, and I'm here for it because that's what needs to happen. But I want to acknowledge that, and sometimes it may feel funny, for lack of a better word, not in the like ha 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 funny, but it may feel weird sometimes because of how fast paced those dynamics are changing and have changed. Call routing is something that comes up often. Everyone knows that the way I'm assuming everyone knows that if you dial 988 right now, you're going to be routed to a call center or a contact center based on your area code. And so if I moved to Maryland and I had a Georgia area code, then I'm going to be routed to the call center in Georgia. not in Maryland. And so questions come to play. Well, how does that impact response time if somebody actually needs a in-person type of response, like mobile crisis, et cetera? And so we are looking at what geo-routing could look like. So we are in a testing phase there. And when I say testing, not a live, it's not anything you all can see forward. This is looking at data to see what could the possibilities be here, which is different from geolocation. And so geo-routing pings to a cell tower. And so that gets us at least closer to where an individual may be in the event they need access to localized supports. And so that feels important. People have many different opinions about this. For me, our perspective is this is a national local partnership. And we want people to get connected to contact centers that are local where that is possible, so that in the event they need something post that call. Even though consistently we find that the call itself is the intervention and most things are managed via the call, but in the event someone needs something else, we want to be able to, for that person to be able to access something local for them. So that's it, that's the goal. Long-term sustainability is something that comes up often. Like, what does this look like in the future? Right now, here's what I know. You saw the other slide, you saw the dollars. Right now, we are supporting states and territories with many different funding streams in different ways to help build out these systems. It is a partnership. And so it does take both state and state and federal funding right now to make this work. And so long-term sustainability is a conversation that we'll continue to have. We will continue to provide technical assistance on. But I know from talking to states right now that you cobble together your funds in many different ways to make all of this work. But there is that question. And so right now, what I would say is that we're continuing to look at what does this look like? And right now we're trying to just make sure that we can support you all as best as we can. Equity and workforce will just continue to be big drivers of the work, big challenge areas, but none that I don't think that we won't be able to collectively address. Partner and consumer engagement. And so this is what happens when they let me come outside by myself. I'll preview this too. I was in a different setting today, and I said what's really important to me as we move into this next year, or moving into year 2 now, is I need some feedback loops. And so looking at ways in which we can engage with key stakeholders across this country on a consistent basis, so that we can stay connected to what is happening in real time on the ground, be advised around, what feels like needs to be lifted up. And so we're looking at different ways in which what that could look like, so that we can be more strategic, that we're not losing individual consumer voice, that we're not losing provider voice, that we're not losing the things that are critical to drive the system. I can't work that way. And so we need to figure out these engagement loops and these partner engagements. And so we'll continue to be on the lookout pretty soon on what that will look like. I said marketing the 988 Lifeline, but I'm gonna still say it again. Marketing the 988 Lifeline is something we will be driving towards as well. But this looks just like it was Saturday, right? These are the things that just continue to be huge drivers and just challenges as well. Not all challenges are bad. We're up for it, right? And so that's where we are. Next slide. So the big picture is we are not just talking about 988. When we talk about this crisis continuum, you all are very familiar with what else are the parts of the system. People ask me about what is this blueprint? And this blueprint, I'm like, well, the providers, people know what the blueprint is. Like, it's not like it's really unknown. It's how do we make this consistent? How do we lift it up? There are places doing fantastic work that have full robust systems of care as it relates to the crisis continuum, and still would say, we got more work we got to do, right? And so how do we get everybody on the same like kind of playing field is what it feels like. There are some states that are very advanced in this space. There are some that are in the middle, and there are some that are just starting to think about what can their systems look like. It doesn't really matter which part of that you fall into. You're talking about building out the system. So a part of what we want to help drive and help support is, here is what that system looks like. We've published papers, SAMHSA has published papers on this, but even those become, as soon as you publish them, they're almost already outdated, right? Because the system evolves so fast and you learn so much about what works, what didn't work, what works in this part of, in this rural part of a country, but that rural part looks different than this rural part. What works in this urban part versus this urban part? What works for this tribal community versus this tribal community? So there's so many things that go into building out this blueprint, but I do think that we can build that blueprint together by lifting up the models that seem to make that seem to have the best outcomes, and that's the type of work we're going to do. So you know what some of those components are. This is not an all-inclusive list. Mobile crisis, stabilization centers. There's things a part of the continuum that's not here in this conversation, but that definitely plays a part. Assertive community treatment is a high intensive type of a service. It is a part of a continuum, right? And so how do you bleed together all these different services that are out there to really create a seamless way in which a person that is needing crisis services can get connected and get access to those services without it being a jigsaw puzzle to figure out? That is the blueprint that we should be driving towards. Next slide. So this is just a slide that says what I already said, which is this a group project. So I'll let the picture just sit with you for a second, but it is a group project. We need all of these entities, all of these places play a role. So I want to make assumptions that every state, every provider is doing the right level of collaboration with all of the people in this ecosystem. And this is not an all-inclusive listing of people in the ecosystem, but these are all your key stakeholders, right? And then some. And so locally driving the work by building from and working with partners locally, such as what's listed here. That is how we get to the ecosystem that we're really talking about, because not everybody's going to come to the behavioral health system through the door we say this is the door. They come through 988 door. They're going to come through all types of doors, right? And so how do we make sure that there is no wrong door, and that whatever door you go to, that you are appropriately either diverted to the right door, and then get what you need, or that if that is the door, how do we work with and collaborate with that entity or that stakeholder, wherever it may be, to make sure we can help get you what you need. I hope that makes sense for folks. Next slide. So I'm wrapping up. This is, I believe, my last slide. I want to leave you here. I'm sure you guys will get this slide, but you see that SAMHSA has a 988 partner toolkit. It is fabulous. If you haven't spent time with it at all, it has a lot of really cool things in it that you can use, that you can print, and help spread the word around 988. There's a lot of new things that there are a lot of things that get updated. And so you may have said, oh, I saw that like a couple of months ago, look again. So we try to keep that current so that we can have information and materials that you find useful as we continue to help get the word out about 988 and the work that is happening there. At the end of the day, we want people to know that help is here. And these are some tools and some things that you can help us help you spread the word as well. I think that's it for me. Can we see what's on the next slide? Yep, I was right. So thank you all so much. If you have questions, 988team@samhsa.hhs.gov is our email box. It is real. We actually answer the questions. We're happy to, engage with you anytime, reach out. We are here. We're real people. We're not robots sitting somewhere. We're real people. So we are here to engage. And I hope that you all, if nothing else, remember to take a moment locally. And if you haven't already done so, please just sit in the moment and celebrate what you have done. What you have done. Look at what you've done. We're literally changing this country in the way we will be talking about behavioral health. We won't be around to see probably the full what this looks like in about 50 years, but you're laying the groundwork and you're planting those seeds. So please take the time to celebrate the space and celebrate the work. I thank you, and I am so full of gratitude for being a part of this group project. Thank you.
Thank you, Monica. Next slide, please. So my name is Brian Hepburn. I'm the Chief Executive of the National Association of State Mental Health Program Directors. And I could basically just say, I agree with everything that Director Johnson just said and sit down. But I have a few things that I'd like to share. But I did want to start with the fact that that was a really excellent presentation, and what Monica put out, I agree with 100%. And I'm afraid that I won't have much to add, but I'll try a little bit. So it's really a pleasure to be on the webinar with Director Johnson and Chuck Ingoglia. The leadership of SAMHSA and the National Council has really provided the needed focus to make 988 and crisis services a national movement. And similar to what Monica was saying about the people in the audience, the people that are working on this, this is truly a movement across the federal government, across the states, the territories, the providers. It's so interesting to be a participant of this. I don't want to go ahead without thanking the NASHBID and National Council staff for putting this webinar together. They do excellent work, so I wanted to bring attention to them, and to the success of these webinars are really related to these individuals that work tirelessly on making sure that it's good content and good outcome. I also wanted to say something about the 988 JAM Learning Center. I'm not sure you all know about it, but it's every Wednesday at noon Eastern time. And it's really a nice learning community where you can keep up with what's happening regarding 988 and crisis services. Also, I want to bring attention to the crisis talk that you can find on crisisnow.com. It's also, if you want to go to talk.crisisnow.com, you will be able to find it. I think there are close to 140 articles now for crisis talk, and they're all related to crisis services, and most of them now are related to 988 and crisis services. I don't think you'll find any better information than what's on Crisis Now and Crisis Talk. With NASHBID, and let me just give a few words about NASHBID. It's a national organization that works with states and territories. The goal is to try and improve the access and improve the quality of services for individuals who need mental health services. We started working on Beyond Beds 2016, and it was because we kept hearing, we need more beds, and we would say to journalists who contacted us, we would say, well, maybe we need more beds, but we really need to beef up the full continuum of care. If we can beef up the full continuum of care, maybe we won't need as many beds. Then the next day, the article would come out and it would say, we need more beds. So we decided what we needed to do was focus our effort on the continuum of care. So since 2016 and the papers coming out 2017, every year 10 papers have come out supporting the effort for a continuum of care. And that has happened through our papers and through our transformation transfer initiative. moving forward with continuum care into crisis services, and then 988 crisis services. So this is really a full effort that has involved NASHBID and now involves all the states and territories. So it's something we're very proud of, and we're fully into 988 and crisis services. Similar to what Monica just said, I want to congratulate all of us, but also to say we're just at year one. When we look at 911, it took 10 years for them to really penetrate to full scale. And we're just at the end of the first year. We need to celebrate, congratulate ourselves, and then look at what else we need to do going forward to make sure, as Monica was saying, in 50 years, people will look back and look at this movement and be very proud of the efforts of everybody. So I wanted to draw just quick attention to the key milestones, the FCC coming out with 988, then the unprecedented amounts of federal and state funding, as Monica addressed, that went towards the crisis continuum. State legislation to create systems that work to provide for the individuals who are in crisis, which resulted in 6 states with 988 telecom fees, 8 states with advisory boards, 12 states with trust funds, 8 states who strengthened insurance for crisis services. 6 states are studying financing or service gaps, and 29 passed budget appropriations. I want to highlight the tremendous growth in mobile crisis services and crisis intervention and stabilization centers, and bring attention to where we have the full crisis teams of mobile call centers, mobile crisis and crisis stabilization. In those areas, in those communities, we find that over 70% of the individuals referred are able to be diverted from higher level services. That's very important because we're not only doing what's best for the individual, what's best for the person that needs the service, but it's also cost effective. Next slide, please. Wanted to highlight recent publications and collaborations that have occurred with SAMHSA, with Vibrant and other organizations, providing resources to support states and system components. Here are some screenshots of the covers of papers that we have written on, are available on the NASHBID website at nashbid.com. First, the template for 988, the model bill template that many states have modeled their bills after. We have details of financing components of legislation. We have workforce challenges and barriers. And then, as I identified, we do 10 papers a year from crisis to care, where the 10 papers from last year that talk about the service continuum and the move forward. Again, all these papers are available at nashbid.org. Next slide, please. Continuing on, we have the TA Coalition, Social Connectedness, a paper, a key component to youth mental wellness, including youth with serious mental illness or emotional disturbance. This was done because what we would hear so often is, what you've done is really developed a nice crisis services template description for adults. You haven't done a very good job for children and youth. So that made us come back and look at what we need to do to really highlight the needs of children and youth in the crisis arena and come up with best services, best practices for addressing those crisis needs. The other paper, 988 Convening Playbook, this is something that was done with SAMHSA and McKinsey and other organizations. This provided a playbook on what needed to be done for successful implementation of 988, focusing on states, territories, and tribes. And again, this is available at our website, nashvid.org. Next slide, please. I wanted to give a couple of examples of states that have done good things, and by no means do I want to say that this is the only place that there's good work. All across the country, you have local jurisdictions that are doing good work. However, Oklahoma Grand Lake Mental Health Center, which is a CCBHC, has done some great work when it comes to addressing the needs of individuals in a rural area where you have a workforce challenge, you have an access challenge, and they have done a really good job of using iPads in order to help improve communication. The first distribution was law enforcement, sheriff's departments, EMS, and hospitals. The second distribution was through local entities, and the third was through 724 locations. The goal was to make iPads available to individuals who have serious mental illness, who would be able to press a button and immediately get access to a team that could help them with their needs. The same thing was done for law enforcement. If law enforcement needed access to the treatment team, they could press a button on the iPad and get the needed supports. This has been such an important effort. It has shown how in areas where you have a lack of resources, you can use technology and improve access and also improve quality. They've done such a good job. They have decreased dramatically the number of people that have been referred to emergency rooms and inpatient. Next slide, please. With Connecticut, I wanted to highlight Connecticut, but going along with the criticism of our efforts that we often treat children and the children as if they're little adults with our programs, the Connecticut developed a really nice program of being able to focus on children and families. And they did it through using mobile dispatch technology, including geo-tracking, real-time appointments for children and youth. They were able to identify peak demand times, enabling them to easily adjust staffing, provide for mobile services, seek psychiatric consultations, access centralized 211 for psychiatric emergencies, and provide direct contact with a licensed staff person and use a decision-making dispatch tool. Both the Connecticut model and the Oklahoma model, the information on those two, it's available through the Crisis Now articles that are available. So if you go to talk.crisisnow.com, you will be able to get access to these articles. Or if you want to just do 988 and Crisis Talk, Google 988 and Crisis Talk, it'll take you there as well. And just search for Oklahoma or Connecticut and it'll come up with those articles. I think that it's really good information and gives you an idea of what can be done when you're focusing on specific populations and also through technology. Next slide, please. So similar to what Monica was talking about, taking 988 and crisis services, next steps, how do we take it beyond year one? How do we take it to full scale? Because that's really what we're talking about. We have good examples all across the country, but it's really talking about how do we improve for marginalized populations, rural populations? How do we make sure that the access that we often see in the urban and suburban areas is taken across all areas, rural, frontier, and hitting all populations to make sure that all marginalized populations are also able to gain access. And the way that we do that is through doing needs assessment, publicizing 988, focusing on marginalized populations, addressing the fear that some populations fear that they have of calling 911, and help them to realize 988 is different and that you'll get someone to talk to, not a dispatcher sending the police. And we want to underline that we want to work effectively with the police. What has happened is that frequently law enforcement has been put into situations for which they're not trained or not prepared. We still believe that police are important, but we want to make sure that they're brought in when they are needed. We want to convince providers to look introspectively and make sure that we're treating individuals based on the culture that that individual is coming from. Focus on prevention and what we can do in terms of helping people to recover so that we can keep people from having crisis, but if they do have crisis, then helping them to recover so they will not be at risk for future crisis. So next slide, please. Want to talk a little bit more about taking 988 and crisis services to the full scale, looking at financial stability, sustainability. And when I use the Arizona, Austin, and Connecticut examples, if you click on those three, each of them, you'll be able to get the paper that it's associated with. So just wanted to identify that we will see cost savings and cost shifts as we implement this model. It will be cost effective. We will have EDs and inpatient days go down. We will have, as long as we have grants, we will have the continued flexibility need that comes with grants. When we talk about the Arizona model, what the Arizona model has shown is that 71% of mobile crisis treatment responses were resolved without transport to a higher level of service. 70% resulted in no ED visits or hospitalizations within 45 days of the encounter. The Austin, Texas paper, clinicians embedded in their 911 centers through 2021 diverted over 5,000 calls and saved $12.6 million. Connecticut, as the mobile crisis teams diverted 553 Medicaid youth. That's the paper that if you click on this in Connecticut, you'll have access to it. But also if you go to Crisis Now, Crisis Talk, you'll be able to find it that way as well. But their savings was $12,000 per youth. So implementing this model will be cost effective. However, one of the studies that was done by McKinsey showed that over 25% of the individuals who were receiving crisis services had private insurance. So we need to get the private payers involved. That's one of the challenges. And we have been reaching out, SAMHSA has been reaching out, NASHBID has been reaching out, National Council has been reaching out, so that we can bring the private sector into the movement. We also have to do a better job of getting telecom fees. We know that telecom fees are very supportive of 911. We need to try and do the same with 988. So we've accomplished a great deal. We still have a long ways to go. Thank you for your attention. Thank you for your participation. Now it's my pleasure to turn over the webinar to Chuck Ingoglia from National Council. And thank you, Chuck, for all the good work that you have done.
Well, thank you, Brian. It's a pleasure to be part of this webinar today. And I need to start by thanking SAMHSA for their incredible leadership over the last year and a half to get us to the point of 988 being a reality. SAMHSA really has stepped up and been an incredible force for change on the national level. And certainly, Brian, thank you to NASHBID and for the work that you do every day with your commissioners for them to focus on this issue on 988 and crisis services. You know, it was great to hear both you and SAMHSA talk about our need for a full continuum. We want to make sure that people can access care when and where they need it. and not have to have a crisis in order to access care. The evolution that we've had from the call center being solely a federal responsibility and the recognition with 988 that this is a joint federal state responsibility. And I think what I want to talk about today is, we talk, this is 988, that next steps. What's our opportunity to longer term really embed crisis services as an essential part of community response? Because if you think about 911, it's not just about the fact that there's this number, but there's this fact that there is this organized system of care available to respond to people at a time of crisis. And so I'm going to be referring in my discussion to this paper that the National Council released in cooperation with the Committee on Psychiatry and the community, and the community for two different psychiatry groups that we work with to release this paper called The Roadmap to the Ideal Crisis System. And if you go to the next slide, really the idea here, if you think about where we've been in this last year, I have to thank also Congress for getting us where we are, because Congress has invested millions of dollars to increase call center capacity. And those impressive numbers that Monica reviewed about answer rates at call centers around the country, that's a direct result of the investment that has happened that has allowed call centers to hire more staff in order to then respond to the increased number of calls. And we've talked about, so you think about the millions of dollars of investment that has been necessary just to create kind of sufficient capacity to answer calls. And we've talked also about that we need to have sufficient crisis response and crisis receiving facilities at the local level. That's going to really require, I think, not just incredible investment, but also, I think, reimagining what we're talking about here. And again, let's compare this to 911. Think about how our systems work nowadays, right? In most places, there is some crisis capacity, but you have to know where to call in order to get it. There might be multiple crisis lines. There could be multiple people who provide crisis services, but it's all kind of fragmented. The individual user needs to know what to do that. So could you imagine calling an ambulance and then maybe two show up because it's not coordinated, or that the ambulance needs to take you to a hospital, but they have to call and see which hospital has a bed, right? Well, we put up with that every day right now in terms of behavioral health crisis, that it's all kind of haphazard in a way. And I think what I'd like to try to introduce to you is beginning to have conversations. Monica talked about the transition that's happened from this just being federal to involving states. And then how does this begin to then work at the local level? Part of what we also acknowledge is there's still not a lot of awareness of 988. So as we build awareness, we want to begin to invite people at the local level into conversation about what is possible in the future. How do we really develop a behavioral health crisis system that's more than just, a kind of this disconnected array of services? but we want to really, think about an organized set of structures, processes, and services to meet the needs of communities, and that there is communication and financing and stability there in order for that to happen. So again, this paper has a lot more detail, and I encourage you to take a look at it, but it's really about how do we begin having local conversations. It's maybe also, if you think about 911 is about essential community services. Do we have, I think we might have an opportunity over time for behavioral health to be thought of in a similar way, right? As essential community services that are financed and stable. So the next slide, and again, if you think about the comparison to 911, one of the first things that had to happen as 911 became a reality is that there was this notion of accountable entities at the local level. Dr. Joe Parks, my medical director who worked on this paper, continues to talk about ambulance districts, right? Really understanding having accountability at the local level. And, I think to the point that Dr. Hepburn just made, that this is all payer, that it's stable, that that we're thinking about adequate, kind of resources at the local level. I'm going to go ahead 2 slides. I'm just nervous about time, so let's go ahead 2 slides. Again, I think the opportunity we have is to begin to have conversations at the local level, building data, and that, I think the other, the data systems and the reporting is going to be really important, because I think right now the sense of our system is that it's a black hole. People don't really know how many people are treated, what the course of that treatment looks like. And so I think the other opportunity we have is to think about kind of local accountability systems. And that will be really necessary as well. So I want to make sure we have some time for questions. So I just want to really encourage people to put on their future hats, to really be thinking about, yes, we've got to shore up what we have now. 988 is a great beginning, but I think we have opportunities over time to really change the conversation, to normalize behavioral health. We have, as Monica mentioned in her opening comments, I think the general public has an appreciation for behavioral health issues, responses, treatments like never before. If there's anything resembling a silver lining associated with COVID, that is it. I think 988 people understand. I've been in this business for a long time, and trying to explain to my family sometimes what I do and what it means, they don't always get it. But when you say that we have a 3-digit number you can call if you're having if you're suicidal or in a crisis, people understand that. And so I think the opportunity we have now is just to begin to have those more conversations at the local level, to connect the stuff that's happening in Washington or even in our state capital to what's happening here, making it really real and discreet and actionable. And I think over time, if we think about accountability and metrics and accountable entities, that we have opportunities to really improve the future for individuals and communities. And with that, why don't we stop and have some time for Q&A?
Yeah, thanks everybody. My name is Matt St. Pierre, and I'm a director at the National Council for Mental Wellbeing. And I have been collecting as many of the questions as possible that have shown up in the chat. And so we're going to take some time in our last 15 minutes here to get through as many as we can. So one that came up during, Monica, your time was, I work with low-income families who sometimes have their phones turned off due to lack of payment. Is there something in place or planned to be in place with cell service providers to keep the 988 option open like 911? That question is from Lisa.
It's a great question. I don't have anything to report about that right now, but it's a really good question to raise up. So I'll definitely take that with me. It's a really good concept, and yeah, so I don't have anything on it today, like no, here's what we're doing on that. But it was something good that needed to be lifted up. And Matt, while I have the floor really quickly, I have quickly scanned. And so someone had mentioned veterans and proud population. And so I do want to go back to that because I would be remiss not to talk a little bit about that. And so the VA is a critical partner with SAMHSA in this work. And so, yes, when you call 988 or reach out to 988, that you will, the first option is to press 1 to be connected to the Veterans Crisis Line. And so that is through a partnership that we have at the federal level. It's an important partnership even before coming to this space. And so I didn't identify them as a key priority population. And so I just wanted to go back and make sure I address that.
Yeah, of course. Thank you very much for expounding upon that. Okay. Kind of to the panel here, Gary G brought up, kind of paraphrasing here, that, as you said, Monica, different states and different communities are in different places as to kind of what services they have. Maybe some communities do have mobile crisis teams or crisis stabilization units, and some may not. So is there a plan or a strategy to kind of continue to develop funding support for expansion of filling in those gaps in local communities?
So this is one of those conversations that there's a state and federal. So at a federal response, I think there are grants out right now. If they're closed, they were out. That came from a different shop within SAMHSA around mobile crisis expansion. And it didn't just have to be like mobile crisis, it allowed for other models, but those went to states. And so providers being connected to, what's flowing into your states is always going to be important there. And then even just kind of thinking back to when I was at a state, that oftentimes there may be funding available, like figuring out what is the need in the community and the stakeholders who are invested in that community, what are they investing in? And so making sure that you're tying together, like in my local community, here is the pressures that are happening at the hospital is seeing too many people in EDs not being connected to housing, whatever it may be, right? So that's a pressure in a local community that may look a little different in a community over. So I think a lot of this is not, so we're saying state and federal, but I really want to emphasize when I say local, communities look very different even within, right? And so how do you leverage the need backed up by data and all those type of things to those people who are elected city officials, county officials, whatever it may be in those communities, I think also is an important layer here. But from a way federal lens, yes, where we can, we definitely support those efforts, and there are grants and whatnot out there now for this exact type of work.
Great. Dr. Hepburn, Chuck, anything you want to add?
Let me just quickly add on the state level that there are some states that have passed the telephone fee so that a certain amount per month, similar to 911, a certain amount per month is attached to everybody's phone bill. And that's the way that 911 is paid. And that's the way we would hope that 988 might get paid across the country. So far, there are only, I believe, 6 states. I think that's the number. But there are a number of other states that are looking at using that fee. There are some states that it's part of their political ideology, their philosophy. They would not use a fee because they believe that it's the same as a tax. What we have seen, and this goes to what Monica said earlier, there's really this bipartisan support we're finding that in many of those states, they're basically passing additional funding so that all state general funds will be able to be used in order to support and expand 988 access. So I think it's a really good question. And from the state standpoint, they feel very comfortable about what's happening right now. The big concern is what's going to happen 3 to 5 years from now. Right now, you've got SAMHSA, you've got CMS, all focused on the success of 988. You have state legislators all focused on the success of 988. But is that going to be sustained over the next 3 to 5 years and beyond? That's the concern.
Well, and Brian, that's why I think it'd be so important to begin having these conversations at the local level, right? Because there's all kinds of resources that are going in right now to inappropriately take care of people with mental illness or substance use disorder in local jails, other kinds of institutions at the local level. And how do we begin thinking, begin having these conversations, imagining a different future? So it might not be additional resources, but how do we redeploy existing resources in a more effective way for everyone?
Yeah.
Wonderful, wonderful thoughts. I'm just like trying to get through as many as possible here. There was a comment that an idea would be parity with 911 could also include financing like mobile crisis teams. Seems similar to how 911 also includes, like Chuck, you were talking about that organized system, the fire department, law enforcement when and where appropriate. But any thoughts on what parity means as we think about like this new expanded crisis system?
Well, I think Brian talked about it a little bit, right? It's how do we get to a point where, well, first of all, the whole idea of payment within crisis is kind of a new thing, right? It's not something that we necessarily have thought about. But if we're going to be going down this road, how does it become an all-payer kind of system? And so we've had movement in Congress to help better fund crisis, mobile crisis through Medicaid. Some movement around what it's going to look like in Medicare. And then I think the last big hurrah will be, what is this going to mean for private insurance? And that is a work that continues to be in progress. Brian, anything else you can say about that?
Yeah, I think that you're right on, Chuck, that the idea of trying to get, people often look at crisis services as a public service or a public model. And I think that's part of the question. Is this something that should be paid for the same way as law enforcement, ambulance services, et cetera, where it may be that there's a certain amount of money that's put in by as part of public payment, right? So it's not fee for service, it's not part of the insurance industry, but we don't seem to be seeing that, right? So we seem to be seeing it as going forward as part of healthcare, and that seems to be where there's more promise to be able to get it covered, even though many of us like the idea that it might be done the same as law enforcement in terms of payment. It seems like it's going to continue to be part of health and healthcare, and how do we do a better job of parity for mental health as compared to physical health, so that we do get equal coverage. But it's a good question, and it's something that's going to be increasingly an issue as we move beyond the next couple of years, when there's going to be less and less federal funding. Right now, as Monica said early on, the federal funding has really made this so much easier, because we are blessed at this point with a lot of money, and that's made it easier to get the work done. What's going to happen if things tighten up or money is taken back? It could be problematic. So.
Thank you. We had a kind of a workforce training question. Workforce is always a hot topic. So there was a question about any addiction or reentry specific lifeline and or crisis worker trainings for hotlines. They cite background checks can be a huge hurdle when applying for training and employment. even if it was a long time ago or a minor charge? Is there anything being done to help accommodate that population? That's from Tina.
So I'm not sure who would be best to answer that. I'll take a little bit of it. So I don't know if that question is best answered by us. And so I could just say that there is a wide variation around policies or other requirements that go into what decisions made into background checks. And so I think that I don't want to speak to the background check issue because I think that that's such a local, so I won't lean in there. I get the question and why it poses a challenge. I think talking to each other, because I do think that some states have done some things to alleviate some of the hurdles there. So I do think that that's more of states communicating with each other in the other platforms in which you have. I think there are some lessons and probably some things that other states have done that can maybe be shared.
I'll just jump in a little bit to say that, part of the problem is that we are dealing with a workforce crisis. So that we may not be able to hire people that have all the background that we would like in terms of experience with addictions, with substance abuse, with mental health issues, right? But then what we need to do is make sure that people have the necessary training in order to help whoever calls. I mean, part of the challenge is that we've set this up as no wrong door, so that whoever calls will be able to get the help that they need. Now, that doesn't mean that the person who initially answers the phone is going to be an expert in everything, but we should have it so that if there's somebody calling with an issue that's broader than what they can address, that they have access to a backup that will be able to provide that additionally needed information.
Okay, well, I want to be respectful of our presenters' time. I'm going to drop one more resource in the chat just because 988 and 911 have become such a hot topic today that were discussed at length. So here's a fact sheet that helps kind of compare and contrast 988 and 911 and gives some quick data. But on that, I will hand it back over to Kelly from Nashville to close us out. And thanks again so much to all of our presenters and helping us mark this historic occasion of the 1-year anniversary plus 1 day of 988.
Thank you, Matt. And thank you again to our presenters, Monica, Dr. Hepburn, and Chuck Ingoglia, excuse me. And we'd like to thank you all for spending the afternoon with us. If you would take a moment to fill out the survey as you exit the presentation, that would be wonderful, and just share your feedback with us. We'd like to give a special thank to SAMHSA for allowing us to share this information with you, and we hope you enjoy the rest of your afternoon. For the presenters who can stay on, please do. Others, enjoy your afternoon and have a good day. Bye-bye.
Thank you. This concludes today's presentation. You may now disconnect.